Good evening. My name is Kayla Megwa. This is Vital Signs on the Frontlines. On this edition of the program, we continue our critical analysis of the primary healthcare sector and the issues within it which confront millions of Nigerian families who rely upon it, with the Executive Director and Chief Executive Officer of the National Primary Healthcare Development Agency, Dr. Muyi Aino. We turn our attention to maternal and newborn healthcare in Nigeria. The federal government's new IEV strategy, which is the Identify, Enumerate and Vaccinate strategy, led by the NPHCDA, seeks to improve immunization coverage in every locality of the country. Is this a final solution? We asked the Executive Director. Maternal and newborn mortality reduction, innovation and initiative, that is called MANI. Is across 172 priority local government areas. Well, tell us what kind of work your office did in that regard.
So one of the primary outcomes that the presidential compact that I earlier referenced focused on is reducing very rapidly preventable maternal and newborn deaths. The numbers vary depending on who you ask and where you look, but I think what we can all agree on is that there are too many unnecessary deaths among our women and our newborns because of failures in the system to support them in the way that they need. So the Maternal and Newborn Mortality Reduction Innovation Initiative, MAMI, was flagged off by the Coordinating Minister for Health to try to tackle that. And what my agency did in collaboration with states and the SWAP office, I think it's important that you know that my agency is an enabler. We're not primarily, we intervene to implement when there are gaps, but primarily we're to enable and develop the system. So we always work with the states, we work with the Federal Ministry of Health, we work with other stakeholders. What we did was even lead that analysis to identify, okay, Nigeria is very complex. There are 774 local governments. Women are dying everywhere and newborns, and every life is important. But are there places that are contributing disproportionately? And we found 172 local governments across 33 states that contribute 55% of the deaths. So we designated those as the starting points. So it's not going to be limited to this 172, but you have to start somewhere. You can't go everywhere on the same day to demonstrate it. And what MAMI does is very simple. It is that when a woman is pregnant, if you are aware and you have contact with that woman, you can follow them through the stages of pregnancy to make sure that they get all of the care that they need. When they should attend antenatal, you follow them through to make sure they attend it. When they should get their blood work done, PCV, they get it done. When they should check their urine for proteins to screen for other things, you do that. When they should get an ultrasound scan to know what is the risk, what's the placenta location, the lie of the baby, they get that as well. Missing on some of this is the reason why many women present with complications that then become too difficult to manage. So what we're doing is trying to be proactive, that when you're a pregnant woman, we want to register you and we want to link you with a primary health center who will support you through all of this in a way that is funded, by the government, national and state, collaboratively, and in many regards, in many cases, also covered by insurance. And the idea is even when a woman is at risk of complications, we already know that they are already linked to what is called a CMONC facility, which is the specialist, the advanced general and teaching hospitals, where they can get treatment and management for complications of pregnancy, whether it is postpartum hemorrhage, whether it is eclampsia or preeclampsia, whether it is maternal sepsis or infection, and even advanced resuscitation for newborns. It's not everywhere that you can really, of course, every PHC is being supported now to be able to do basic resuscitation of newborns. But when there's a complicated birth, first, you want to try to make sure those complicated births happen in facilities that are equipped to handle them. But those facilities then also need to do advanced resuscitation of newborns.
There's something that is called the IEV strategy.
Yes.
And it's been applauded across the globe, zero-dose children.
Yes.
Maybe you could talk to us a little bit about, the design and the rollout of the IEV strategy.
The rationale behind the IEV strategy, it's become a thing now, but when we came in, we basically said, look, we have too many children that are unvaccinated. We're having outbreaks left, right, and center because children are missing vaccination. Children don't make the decisions to not get vaccinated. So it's usually one of two things. Either you have misinformed adults that are refusing to access, or in fact, you have failures in the supply system so that even when people want it or are open to it, somehow they don't get it. So we did a mapping of locations where you have clusters of children that have been missed chronically. And you know that by just knowing where the children that were vaccinated are located and where they are not. But also looking at where there are outbreaks, we also have data on coverage of basic antigens, and we know some of those locations to the ward level. And we said, look, these babies and children, they are the human beings, they're not ghosts. So can we just go and find them? When you find them, if you know who they are, you know who the mother is, you know where they live, even if there is challenges vaccinating them on that day, you have a mechanism to follow up and assign a health worker, a community health worker to follow up. If it is a matter of persuading the father, there are many levers that you can pull. You speak with them, even give them incentives, integrate with other services that they also want to collect. And if everything else fails, bring in the traditional leaders, to come and weigh in and say, look, come and talk to members of your community. So that's what the IEV strategy is at its simplest. It's basically we're creating a roster of children in high-risk locations, determining what vaccines have been missed and doing all we need to do to make sure each of them as an individual human being gets the vaccines that they get. And ultimately, that is what will get over this problem. And I think as at the last count, we have now reached over 21 million children documented, and, close to 1 million of them have been vaccinated on top of what they had before.
This is the largest vaccination campaign in Africa, targeting over 100 million children, and under President Bola Tinubu, Africa's most populous nation seems positioned to lead the charge. Coordinated and supervised by Coordinating Minister of Health and Social Welfare, Professor Mohammed Ali Pate, the federal government since 2023 has vaccinated Nigerians in record numbers. The recently concluded integrated measles rubella campaign successfully vaccinated over 100 million children aged 9 months to 14 years across Nigeria, reaching 59.4 million children in phase 1, 21 states in 2025, and 42.6 million in phase 2, 16 states in 2026. Nigeria's historic immunization coverage since 2023 also includes 25 million measles vaccination doses and 22 million yellow fever vaccinations successfully administered alongside the successful rollout of Africa's first Mpox vaccine.
At first, it was IEV, where you identify, enumerate, and vaccinate. Well, what we found very quickly, learned in the first phase, is that when there are families that reject vaccines or have questions, when you bundle the vaccination with the enumeration, then they don't allow themselves to be, they hide. Then you miss the point. You're not able to know that they exist. So we decided, okay, where it's easy, vaccinate, but if there's some pushback, just enumerate. So that's why we have a lot more children enumerated, and then we're using the primary healthcare system to follow through our community health workers to go after them one by one, like I said, to address all the different reasons why they may be missing these vaccines.
It's a lot of work, especially when you're looking at local communities, rural communities that have a tendency to move with narratives that do not that do not help the growth and development, especially of children, when it comes to vaccinations. How are you, communicating with the village heads and the religious leaders in all of those places to help, sensitize people and help them understand why it's important that these vaccinations are done when they're supposed to be done?
One of the opportunities that we had when we came, that I think is also a good fortune, is that there already was a mechanism, an approach for engaging with communities. In the North, there's the Northern Traditional Leaders Committee on primary health care. Started as polio, then immunization, then primary health care broadly. And what it does is it's a committee of very senior traditional leaders that there's a state representative that sits on a committee and meets with this agency and many times with the minister once a quarter to review our programs, to review our engagement with the communities, and where we have a campaign or an intervention, for example, and there are challenges in the community, they advise us and they help us address this, because whatever we agree in the meetings, they then cascade down. This committee is chaired by His Eminence, the Sultan of Sokoto himself. Now, we are in the process with our partners and traditional leaders in the South of setting up similar entities in the Southwest, in the Southeast, and in the South-South. And the idea being that there's a role as gatekeepers of information and decision for traditional leaders. And they've done a lot. When they participate in our activities, they are part of, not necessarily the emirs at the top, but the lower level traditional leaders as well, the ward chiefs. They are part of the ward development committee that oversees what the facility is doing. So whatever we do, we work with them. They grant us access. When we're doing campaigns house to house, they put a member on the team who goes to say, okay, this is good for us, this is safe for us, can you give them access to your children? So the human papilloma virus, for example, is a major vaccine that prevents, very effective, more than 99% effective in young girls that take it, against the human papilloma virus, which is a cause of cervical cancer. There are not many cancers that you can absolutely prevent. That's one that you can prevent, and the president took it on. We also have an intervention now. There's an upcoming collaboration where one of the largest manufacturers is working with our agency and the Ministry of Health to donate about 4 million doses to make available to older women, who are interested to be, between 16 and 18 or 19, thereabouts, those who missed out on this window. Because between the ages of 9 and 14, 15 now, we have actually vaccinated over 16 million girls, which means these girls have one less thing to worry about. They don't have to worry about the risk of human papilloma virus infection or cervical cancer, and they can grow on to have very fruitful lives, God willing. So that's one. The other is malaria. We understand the burden of malaria, and there are many tools that are available for malaria control, right? We already use a lot of bed nets. We already use seasonal chemoprophylaxis, vector control. Individuals have things that you do within your homes to reduce, mosquito bites and reduce the risk of malaria. Pregnant women, have preventive chemoprophylaxis during pregnancy. But one more tool that kind of adds to all of that is the malaria vaccine. And the president made the decision to introduce it in states that had the highest burden. So we started with Bayelsa and Kebbi. We're moving to 2 additional states now, based on the use. It's a new tool, but, we're deploying it to cover that. We vaccinated about 1,960,000 people thereabouts, as at the last time I looked at the data.
Over the past 2 years, 5 million children have been immunized with pentavalent vaccine, and 17.5 million more children have received the tetanus diphtheria-containing vaccine since the inception of the Tinubu administration's nationwide diphtheria response. With over 12,000 Nigerian women being diagnosed with ovarian cancer annually, the federal government has, since the launch of the HPV vaccination drive in October of 2023, successfully vaccinated more than 16.7 million eligible girls aged between 9 to 14 years, representing well over 90% of the eligible Nigerian girls across 15 states, plus the Federal Capital Territory. The vaccinations are free in all public health facilities. Fully funded by the federal government, the robust set of vaccination campaigns represents a major step towards protecting women and children, reducing outbreaks, and moving Nigeria closer to universal health security.
The measles rubella vaccine is another one. Measles vaccine, we've been given for many years, but rubella is another component that sometimes presents like measles, but the traditional measles vaccine didn't cover it. So we expanded that to measles rubella, and we have, in the first phase of 19 northern states, FCT and Oyo State, we were able to vaccinate 59 million plus, 59.8 million children, which is about almost 100% of the targets that we set based on the population estimate. As we speak, the campaign is going on in the rest of the states in the south, and for those Nigerians that are listening to us, I hope they will, avail themselves of that opportunity for their children and their wards to get vaccinated. Mpox was another one. Mpox was ravaging quite a bit, and we were fortunate to get a donation of almost 10,000 doses from one of our major partners. Even other countries came. We gave Rwanda 1,000 copies, as a big brother. We've been able to vaccinate people in 12 states.
Looking back at everything that you've done, or everything that's happened under your leadership, what would you say is your biggest milestone? And what legacy do you want to leave for anyone who has to head this agency after you?
I think if you recollect, I think you had asked me earlier about why this is personal. I had said that I have witnessed an erosion of trust. If you ask me what I'm most proud of, it is that when you look at the utilization of the primary health centers, the primary health care system, Nigerians are engaging again. People who need care are coming to get their cares. Even those who don't need care, they're talking about it. Positive or negative, but they're engaging. That's much better than when people are zoned out and have no trust or no belief in the system. And the legacy that I would really like to leave for anyone coming behind me is that of a build on to continue to have a functional, better, and trusted primary healthcare systems, where Nigerians know that, the primary healthcare system is doing what it should do, which is whoever you are, wherever you are, whatever your gender, whatever your tribe, whatever your needs, wherever you live, there's a primary health center near you that you can go to and get your basic healthcare services needs met.
Primary healthcare center development is comprehensive, but without power, all other efforts are undermined, which is why the Coordinating Minister of Health and Social Welfare, Professor Mohammed Ali Pate, insists that the solarization of primary healthcare centers will strengthen healthcare delivery, particularly in underserved communities. We were on site alongside the Executive Director and Chief Executive Officer of the National Primary Healthcare Development Agency, Dr. Muyi Aino, as the Coordinating Minister, Professor Mohammed Ali Pate, commissioned new solar power facilities in 371 primary healthcare centers across 17 states and the Federal Capital Territory. Dr. Muyi Aino provided further insights.
So really, this is about the solarization of the PHC. You saw the panels outside. In here is the battery backup for the solars. And this is one of the 371 facilities across the country that were revitalized or solarized through a partnership with Gavi and UNICEF. A few of those are in the FCT, but all of the rest of them are across about 17 states all over the country where this intervention, that's part of the PHC revitalization agenda. Again, remember that one of the objectives of revitalization is for the facility to be able to open 24 hours so that all of these women, they can come in the morning. How are you? It's good to see you. Thank you. Good to see you again. So they can come in the morning, they can come in the afternoon, and they can receive all the services that they need. So if you look on the wall as well, you will see that this is a basic healthcare services. So all clients that are insured by BHCPF, they can come in here to get the insurance. That's all the things that are covered over here. And there's something that we're going to be rolling out soon. I don't see it. We rolled it out in a few places. It's the patient bill of rights as well, so that when they come in local languages, they can know what are their rights, so that they don't get mistreated in these facilities. So, a step at a time, I think we are inching towards the goal. We still have a substantial way to go, but at least we're moving.
The National Health Fellows are changing the face of healthcare in the country. In this profile of impact, we take you to the pace-setter state of Oyo, where Gbadamosi Tawhid Alade, a young doctor from Ibadan Northeast, is innovatively changing the lives of children and mothers in his community with artificial intelligence. Let's hear more from this young pace-setter.
My name is Gbadamosi Tawhid Alade. I am one of the beneficiaries of National Health Fellowship Program, Cohort 1. In Oyo State, we have about 375 human deaths annually per 100 live births. And in Ibadan Northeast, we have about 385 people human deaths in 100,000 live births per annum. MAMI is an AI-powered ANC and PNC reminder kit. MAMI is to help the pregnant woman to remember the time for their antenatal visit, and also to remind the nursing mother for their immunization. Those are the key indicators that contribute to higher mortality ratio in Ibadan Northeast. You can look at some other pictures in MAMI, because the relationship between the nursing mother or the pregnant woman with the MAMI app will be sending a signal to the nearest where they register for their antenatals or for their postnatal visit. And you're sending a signal to them, an integration of sensor. If there's any issue, that you can also try to have an identification. If you're sending a signal to them that the doctor or the nursing or the matron within our facility can relate to, that call for attention, to pick the person immediately to rescue them in any kind of complication. MAMI recognize danger signs to reduce mortality and also to cure all the delays that record to high mortality ratio in Ibadan Northeast. During my National Health Fellowship journey, I carried out another custom project which is called maternal nutrition. I discussed extensively on the importance of exclusive breastfeeding for the first 6 months of the baby. That the importance of breast milk to build the immune system against infectious disease for their infants. These are one of the key indicators to reduce neonatal mortalities in our community. As far as Ibadan Northeast is concerned, we have about 250 high infant mortality ratio. And also, it is so discovered during our sensitization, we have about 65 nursing mothers in attendance. We discuss, they ask questions, we talk about the importance of maternal nutrition in the support of the experts in the nutrition and the OIC. We discuss extensively and people are very happy with the discussion. National Health Fellowship Program is one of the unique programs under the sector-wide approach. It built my capacity, my reason, even beyond being a data analysis, even beyond being an information scientist, even beyond being a grassroots developer. I see health issues. It built my problem-solving skills, my leadership, my community entry, the stakeholder engagement. I've been looking at the issue differently in a broader concept on how to find a final solution. I want to use this opportunity to appreciate the President of the Federal Republic of Nigeria, President Bola Ahmed Tinubu, GCFR, and also Honorable Coordinating Minister, Professor Mohammed Ali Pate, for giving us this opportunity to contribute to the health sectors. The young Nigeria so much appreciate this kind of opportunity to support the renewed hope agenda of the President.
In Dr. Aina's role and the creativity of Gbadamosi's community impact, we see that Nigerians are beginning to engage again for progress, and engage we must. We see clearly that it is our home, and while it may not be perfect, we can together fix the problems before us, while ensuring that our institutions work for our highest good. Next week on the program, we turn our attention to the Presidential Initiative for Unlocking the Healthcare Value Chain, a bold new effort to localize manufacturing and create wealth for all Nigerians while bolstering the overall quality of healthcare in the country. Thank you so much for watching. Until next time on Vital Signs on the Frontlines, I'm Kayla Megwa, reminding you that your health is your true wealth.